Stroke and Manipulation, the 2019 Annals of Medicine Review and Recommendations. The medical community has held to a mechanical hypothesis for explaining the few case reports and case series reports that have assumed manipulation to be the cause of stroke. However, for over a decade, chiropractic researchers have provided evidence that demonstrates vertebral basilar and carotid artery stroke associated with manipulation is likely a progression from dissection, primarily with patients seeking care for headache and neck pain. And regardless of the findings of several extremely large studies that demonstrated that it is as common or more common for patients to have seen an MD prior to these strokes compared to DCs, even national groups still denied the evidence. For example, in the publication Cervical Artery Dissections in Association with Cervical Manipulative Therapy, a statement for healthcare professionals from the American Heart Association and American Stroke Association, published in Stroke in 2014, the groups summarize with the following statement, quote, "Although current biomechanical evidence is insufficient to establish the claim that cervical manipulation causes cervical dissection, clinical reports suggest that mechanical forces play a role in the considerable number of cervical dissections, and most population-controlled studies have found an association between cervical manipulation and vertebral artery dissection stroke in young patients," unquote. Yet others, such as the World Health Organization, have stated that it, quote, "considers manual mobilization and/or spinal manipulative treatment conducted by chiropractors to be a safe and effective treatment with few, mild, transient adverse events such as local soft tissue tenderness and tiredness on the treatment day," unquote. At long last, a publication in the Annals of Medicine in 2019 has presented a review of the existing evidence that has largely been ignored. It is entitled A Risk-Benefit Assessment Strategy to Exclude Cervical Artery Dissection in Spinal Manual Therapy, a comprehensive review. We will approach a discussion of this publication by first reviewing their conclusions and briefly reviewing the reference support for these conclusions. Then we'll move to the recommendations by the researchers regarding the risk-benefit approach that largely focuses on identifying those at risk for dissection. Note, this is not a statement about who should or should not be manipulated, but who is at higher risk for dissection regardless of activities of daily living or a visit to their health care provider. The authors state in summary, in light of the evidence provided in this comprehensive review, first, there is no firm scientific basis for direct causality between cervical spinal manipulative therapy and cervical artery dissection. Two, the internal carotid artery moves freely within the cervical pathway. And three, 74% of cervical spinal manipulative therapies are conducted in the lower cervical spine where the vertebral artery also moves freely. Four, normal activities of daily living, including rotations, do not trigger cervical artery dissection. And five, cervical manipulation and/or grade C cervical mobilization moves beyond the physiological limit of facet joints, but the artery is not stretched to an extent to exceed failure strain. But first, just a quick review of anatomy and pathology as it relates to the onset and symptoms. The cervical arteries are comprised of the carotid and vertebral arteries. The common carotid splits into the internal and external carotids at the level of about C4. The vertebral arteries branch off the subclavian and travel up through the C6 transverse foramen. At C2, they pass to enter the C1 transverse foramen. Then they travel around the lateral mass of C1 and at the posterior arch enter the foramen magnum. Dissection occurs with intimal tearing, which is due to weakness of the artery that is the result of an underlying inflammatory condition or an inherited weakness in connective tissue in the lining of the artery. With subintimal tears leading to an intramural hematoma, dissections may result in stenosis of the artery, and subadventitial dissections may result in aneurysm formation. So let's move to the first summary statement by the authors. There is no firm scientific basis for direct causality between cervical spinal manipulative therapy and cervical artery dissection. Cervical artery dissection is rare. The mean age is 44 years with a slight male preponderance. Cervical artery dissection is extremely rare in children and adults over the age of 65 years. In a large U.S. study, prevalence of VBA stroke in adults in a commercially insured population was only 0.021%, and in seniors in a Medicare Advantage plan, it was even lower at 0.0032%, not even 1%. Much of the prejudice toward a belief in mechanical causation is based on protopathic bias, meaning what is actually happening is a patient is seeing a healthcare provider during the prodrome of a condition before the presentation becomes obvious enough to warrant further evaluation and before it can be diagnosed. In the case of dissection, it is the presentation of neck pain or headache prior to progression to stroke. And remember, there is no clinical test to detect during this phase. The researchers state that the ability to establish causality is not feasible. They conclude that to confirm cause and effect, quote, a prospective study would need to include 1,000 manual therapists treating the cervical spine 100 times per week for 52 weeks, unquote. So if forward-in-time prospective studies are not feasible, the next step down in the hierarchy of scientific rigor are case control studies. These are appropriate for conditions that are rare or when there is a transient change in risk. And crossover approaches allow the use of the patient as their own control, comparing their health records for when the event occurred compared to when it had not. Now to the first of two large studies regarding VBA. Risk of vertebral basilar stroke and chiropractic care, results of a population-based case control and crossover study by Cassidy et al., published in Spine in 2008. In this review, all adult residents of Ontario, Canada were studied over 9 years. There were only 818 vertebral basilar strokes who were hospitalized. Matching of hospital records, including VB stroke, with the same patient's record of a visit to a chiropractor and/or a primary care medical practitioner was performed. The take-home points? In those under 45 years old, individuals were 3 times more likely to see a chiropractor or a primary care practitioner before their stroke compared to controls. There was no increased association between VB stroke and chiropractic visits in those older than age 45, but there was an association between VB stroke and patients of all ages visiting a PCP prior to stroke. And to the next, even larger study conducted in the United States, Chiropractic Care and the Risk of Vertebral Basilar Stroke, results of a case control study in U.S. commercial and Medicare populations by Kosloff et al., published in Chiropractic and Manual Therapies in 2015. As stated earlier, prevalence of VBA stroke was extremely low. This study incorporated the same study design as the Cassidy et al. Canadian study, comparing visits to either an MD or a DC. In summary, the data indicates that there is no association between chiropractic visits and VBA stroke, regardless of age stratification in either the commercial or Medicare Advantage populations. There was a significant association between PCP visits and VBA stroke, regardless of the length of the hazard period, which could be up to 30 days after a patient visit. And in the Medicare population for chiropractic visits, only 3 strokes occurred in the 30-day period and none in the first 7 days. Let's add up the results comparing MD to DC occurrence. In the commercial population, 20.5% of all VBA stroke cases were associated with either a DC or PCP visit. However, with DC visits, it was only 1.6%, but for PCP visits, it was 18.9%. And also, what about the other 79.5% of cases who saw neither a DC or a PCP? And for the Medicare population, 21.6% of all VBA stroke cases were associated with either a DC or PCP visit. However, With DC visits, it was only 0.3%, but for PCP visits, it was 21.3%. So again, what about the other 78.4% of cases that saw neither a DC or PCP? And now to carotid artery dissection. A review was published in the Journal of Manipulative and Physiological Therapeutics in 2015 entitled The Association Between Cervical Spine Manipulation and Carotid Artery Dissection, a systematic review of the literature. The researchers state, quote, the incidence of internal carotid artery dissection after cervical spine manipulation is unknown, although several case reports and case series raise the hypothesis of an association. We found no epidemiological studies that validate this hypothesis, unquote. Next, the same case control design as the previous two vertebral artery studies was used to study carotid artery dissection. It's entitled Risk of Carotid Stroke After Chiropractic Care, a population-based case crossover study published in the Journal of Stroke and Cerebral Vascular Disease in 2016 by Cassidy et al. Some stats first. Spontaneous carotid dissection accounts for 10 to 25% of strokes in patients age 45 or younger. 70% of patients with carotid arterial dissection are between the ages of 35 and 50. More than 75% make a full recovery, and the risk of recurrence is 2% in the first month and 1% per year thereafter. Specifically, the annual incidence of carotid artery dissection is estimated at 1.72 per 100,000, meaning not even 1%. There were 4 categories of exposure: no exposure, DC only visit, PCP only visit, and both DC and PCP visits. A total of 15,523 carotid artery stroke cases met the inclusion criteria. 5,433 cases, or 35%, had received only PCP services, and only 186 cases, or 1.2%, had received only DC services. The bottom line, for all DC and PCP visits in those less than 45 years of age, there is an association with stroke for both groups, but no significant differences between PCP and DC patients, and no cases who saw both practitioners less than 7 days before their stroke. For stroke cases 45 years of age and older, there is no positive association with chiropractic care or with the combination of DC and PCP care. There is a consistent but weak association with PCP care in the older group. So what if patients presented with headache or neck pain? When researchers restricted the analysis to visits that were either coded for neck pain and/or headache, the odds ratios increased significantly for all DC and PCP exposures in those less than 45 years of age, with one exception. And now to number 2 of the statements. The internal carotid artery moves freely within the cervical pathway. In several studies, Herzog et al. Measured strains of the cervical arteries. Specifically in this study, they measured internal carotid artery strains during high-speed, low-amplitude spinal manipulations of the neck using cadavers. This was published in JMPT in 2012. Similar to VBA testing, range of motion testing strains were significantly greater than the corresponding maximal strains for the spinal manipulative therapies. The mean of all maximal internal carotid artery strains obtained with spinal manipulative therapy was 28% of that measured during the range of motion testing. It was only 10% of the failure strain of the internal carotid artery. They also note that from previous studies, the basic science evidence against cervical manipulation as a potential cause include that the evidence shows that blood flow is not decreased with rotation, that the strain forces with cervical manipulation do not exceed failure rates of arteries, and the evidence that strain forces with cervical manipulation are no greater than normal activities. And now number 3. 74% of cervical spinal manipulative therapies are conducted in the lower cervical spine, where the vertebral artery also moves freely. They refer to one study of patients with acute neck pain where there were 1,235 cervical spinal manipulative therapies conducted by chiropractors. The researchers determined that 74% of the cervical spinal manipulative therapies were conducted in the lower cervical spine. This was published by Heinlein and Cooperstein in the Journal of Chiropractic Medicine in 2009. Number 4, normal activities of daily living, including rotations, do not trigger cervical artery dissection. Spontaneous cervical artery dissection accounts for the majority of dissections and has been reported to be caused by minor traumas to the neck from various activities, such as skating, tennis, basketball, volleyball, swimming, scuba diving, weightlifting, dancing, yoga, and jumping, among other activities which are likely coincidental to the dissection rather than a cause. And number 5, cervical manipulation and/or grade C cervical mobilization moves beyond the physiological limit of facet joints, but the artery is not stretched to an extent to exceed failure strain. In another study by Herzog et al., vertebral artery strains during high-speed, low-amplitude cervical spinal manipulation using cadavers was published. Remember that V1, or the preforaminal section of the vertebral artery, is the area where the artery runs toward the transverse foramen of C6, and V4, the intradural or intracranial section, represents the area where the artery pierces the dura mater to continue to the medulla. We can see that spinal manipulative therapy testing causes about 6% strain at V1, whereas range of motion testing approximates 6% strain for the V4 segment, both below the failure strain prediction level. And regarding accumulative damage from repeated manipulation, a study entitled Microstructural Damage in Arterial Tissue Exposed to Repeated Tensile Strains was published in JMPT in 2010. There was no damage at 6% strain, and according to the available literature, SMT strains range from 0.9 to 6.2%. Yet in this study, it took 1,000 cycles of 30% strain to cause significant microstructural damage to the arterial tissue. And now to the recommendations for detection of dissection and stroke. Headache and/or neck pain are the most common initial symptoms of cervical artery dissection in about 80% of cases. The headache is often new and unilateral with sudden onset and may resemble a migraine or cluster headache. In the case of carotid artery dissection, Horner syndrome, amaurosis fugax, which is temporary loss of vision due to decreased retinal artery supply, may occur, or a complaint of pulsating tinnitus or a whooshing sound type of tinnitus related to the dissection. The time from initial symptoms to ischemic stroke varies from minutes to as long as a few weeks in rare cases. The researchers make some screening history recommendations, including environmental risk factors, which include recent acute respiratory infections, B6, 9, and 12 vitamin deficiencies, a low body mass index, low cholesterol, and smoking. Inherent risk factors include medical and/or a family history of arterial anomalies and/or cervical artery dissection, respectively. Connective tissue disorders, which include Ehlers-Danlos syndrome type 4, Marfan syndrome, osteogenesis imperfecta, or Loeys-Dietz syndrome. And finally, the prognosis for cervical artery dissection is often misrepresented or misunderstood. And although being complex with regard to where and when, at 3 months the prognosis is good for 89% of cases. Specifically, 91% of internal carotid artery dissections and 88% of vertebral artery dissections have a good prognosis. The mortality rate is a mean of 5.1% for internal carotid artery dissection and a mean of 1.3% for vertebral artery dissection. So in closing, we should be encouraged that a publication in a prestigious medical journal, the Annals of Medicine, has reviewed the literature evidence and objectively concluded that there is no evidence of causation for manipulation in cervical artery dissection or stroke. We hope this redirect to the evidence and not the bias of case reports or case series will be recognized and accepted by larger groups. Because of the individual tragedy that occurs with dissection and stroke, it's human nature to, quote, get answers, attach blame, and find a culprit, especially for the individual and their families. Yet it is clear that this is in most cases an unpredictable, spontaneous event. Given that the prime directive of scientific evidence is to, whenever possible, use the least biased evidence when it exists, we finally see some in the medical world following what they preach to others.